So, um, when we think about curing cancer, I feel like we usually picture this like sledgehammer approach.
Right. Yeah. You just want to smash it.
Exactly. The instinct is to just smash the disease at all costs. But sometimes the treatment is less like swinging a sledgehammer
Yeah.
and more like, I don't know, defusing a highly complex ticking bomb.
Yeah, a bomb inside a crowded room. You definitely can't just blow it up.
Right. You have to know like exactly which wire to snip and in what order without taking down the whole building with it.
And diffusing a bomb like that requires understanding the structural integrity of everything around it, too. You're constantly balancing this immediate threat of the explosive against the long-term survival of the surrounding architecture.
That is exactly what we're getting into today. Welcome to the deep dive, everyone. Whether you're an oncology nurse navigating these treatment plans or just an intensely curious learner trying to figure out how the human body works, today's mission is for you.
We are looking at the ESMO European Clinical Practice Guideline for Testicular Cancer.
Which is basically the ultimate manual for diffusing that bomb. This deep dive into those guidelines reveals a total masterclass in how modern medicine balances the really aggressive pursuit of a cure with preserving a patient's entire life ahead of them.
And the stakes here are uniquely framed by the age of the patients, right? I mean, when the word cancer comes up, the immediate association is usually aging, like cellular breakdown over time.
Right, it's an older person's disease usually.
Exactly. But testicular cancer totally upends that assumption. It predominantly affects young men in the absolute prime of their lives. We're talking specifically between the ages of 15 and 40.
That's just wild. We're talking about a demographic that is typically at its absolute physical peak.
Yeah. And to put that into a global perspective, the guidelines note there were nearly 74,500 new cases globally in 2020.
Oh.
But looking at the geography of those cases, it presents this bizarre mystery. The incidence is wildly uneven.
Okay, let's unpack this. Why does geography matter so much here?
Well, a decade or so ago, the highest rates were heavily concentrated in places like Denmark, with like 10.2 cases per 100,000 men, and Norway was at 11.5.
So very high in Scandinavia.
Right, and those specific rates are actually slightly declining now, but, and this is the weird part, the incidence is currently rising sharply in Eastern European countries like Belarus and Ukraine.
Okay, so what is causing that shift? Or just causing the disease in general?
The underlying etiology, like the root cause, remains frustratingly elusive, but the data points toward a highly complex intersection of genetics and environment.
I noticed the sources heavily weigh the role of endocrine-disrupting chemicals.
Yes. These are environmental compounds that basically mimic or interfere with the body's natural hormones. The guidelines specifically point out organochlorine insecticides, noting they have a demonstrated link to increasing the risk of these germ cell tumors.
So environmental exposures, possibly acting as early as, like, in utero development,
Yeah.
are basically setting the stage for the disease decades later.
The environment sets the stage, yeah. But genetics often load the dice. The familial connection is just massive here.
Right, I read this part. It's not just a small bump in risk.
No, not at all. If a man has a brother with testicular cancer, his relative risk of developing it jumps by 6.3 times.
That is a huge jump.
And if his father or son has it, the risk is about 4.4 to 4.7 times higher. So there is a profound genetic susceptibility that's just, waiting for an environmental trigger.
Okay, so understanding who is in the crosshairs is obviously the first step. But once a patient is actually in that demographic, identifying the actual threat is where the clinical guidelines get really surprising to me.
Oh, so?
Well, the obvious flashing red siren would be like a unilateral mass in the testicle, right? But the text reveals initial presentations that don't immediately scream testicular cancer at all.
Oh, absolutely. The symptoms can be incredibly misleading.
Yeah, like 27% of patients experience scrotal pain, which, okay, kind of makes sense. But then 11% present with back or flank pain, and 1% even present with gynecomastia, which is breast tissue growth.
Right. And that variety of symptoms perfectly illustrates how the cancer actually behaves systemically.
Yeah, talk about the back pain first. Why back pain?
So that back pain isn't like a pulled muscle from the gym. It's often enlarged retroperitoneal lymph nodes, which are deep in the abdomen, physically pressing on nerves.
Oh, wow. So it's already spreading by the time their back hurts.
Often, yes. And the gynecomastia happens because certain testicular tumors actually synthesize and secrete hormones.
That's the 1% of cases.
Right. Specifically, they secrete human chorionic gonadotropin, which actually stimulates breast tissue development.
Okay, so to figure out what's really happening, when a guy comes in with these weird symptoms, you'd assume doctors would immediately order an MRI, right? Since it's the most high-tech imaging we have.
You'd think so, yeah. But the guidelines actually position high-frequency ultrasound as the absolute gold standard. Specifically, probes greater than 10 megahertz equipped with color Doppler.
Why ultrasound over MRI, though?
Because the Doppler allows doctors to evaluate the blood flow and the exact internal architecture of the mass in real time. MRI is reserved almost exclusively for cases where the ultrasound is, like, incredibly ambiguous.
Okay, the reliance on ultrasound makes structural sense. But looking at this section on serum tumor markers like the blood tests, the protocol seems almost contradictory at first glance to me.
How do you mean?
Well, they draw blood to look for 3 specific proteins shed by the cancer, right?
Right.
AFP, or alpha-fetoprotein, and BHCG, which is the hormone we just mentioned, the one in pregnancy tests.
Right.
And LDH, lactate dehydrogenase, which is an enzyme that spikes when there's rapid tissue damage.
Exactly. Those are the big 3.
Right, but the text explicitly says these markers have low sensitivity, meaning a patient can have totally normal blood work and still have a massive tumor. So why make drawing these specific markers absolutely mandatory before any surgery?
What's fascinating here is that doctors aren't relying on these markers to find the cancer in the first place.
They aren't.
No, they are using them to establish a dynamic mathematical baseline for the treatment that follows.
Okay, I'm tracking.
Think of these 3 markers, the AFP, BHCG, and LDH, as exhaust fumes from a running engine.
Okay, the tumor is the engine.
Exactly. If those markers are elevated before surgery, the oncology team documents exactly how high the concentration is. Then the surgeon physically removes the testicle containing the primary tumor.
Right.
Once that main engine is gone, those exhaust fumes should clear from the bloodstream at a very predictable biological rate based on their half-life.
Ah, okay. And the guidelines give specific numbers for that clearance. AFP takes, what, 5 to 7 days to have its concentration in the blood?
Yes, and BHCG takes just 1 to 3 days.
So if a week after surgery, those markers aren't dropping perfectly in line with that half-life math.
The oncology team knows immediately that there are hidden microscopic metastases somewhere else in the body still pumping out cancer proteins.
The engine is still running somewhere in the dark.
Exactly. It transforms a static blood test into a real-time tracking system. And what they are tracking usually falls into one of 2 categories.
Right, the mapping part. Let's talk about the 2 main types.
So the pathology breaks down into 2 primary types of germ cell tumors. About 55 to 60% are seminomas.
And those are the slower ones.
Right. These are typically slower growing, and biologically, the cells closely resemble early embryonic primordial germ cells.
Okay, which leaves the remaining 40%.
The remaining 40 to 45% are non-seminomas, and these are like the chaotic shapeshifters.
Shapeshifter.
Yeah, they show a wide variety of differentiation patterns. They biologically mimic all sorts of embryonic and extraembryonic tissues, which makes them highly unpredictable and much more aggressive.
Okay, so once the cancer is mapped out, the baseline blood is drawn, the primary thread has to be physically removed. But before a scalpel is even lifted, the guidelines mandate this profoundly human step.
Yes. Semen analysis and sperm cryopreservation must be offered to all patients, preferably before any surgical intervention.
Which makes so much sense considering the age group.
Exactly. It is the most cost-effective fertility preservation strategy available. We are dealing with men in their 20s and 30s. The protocol dictates that saving their life today simply cannot come at the cost of ignoring their future ability to start a family.
I love that that's explicitly written into the manual. But getting to the surgery itself, the orchiectomy, there's a very specific and kind of bizarre mechanical rule.
You're talking about the incision site.
Yeah. The tumor is removed via an inguinal incision, so cutting through the groin area near the waistline. And the guidelines strictly forbid what they call scrotal violation.
Right.
Cutting directly into the scrotum seems like the shortest, most logical route to the tumor, but it's completely prohibited.
It all comes down to the body's internal plumbing, specifically the lymphatic system.
Yeah.
During fetal development, the testicles initially form high up in the abdomen, and as they drop down into the scrotum before birth, they drag their blood vessels and their lymphatic drainage pathways down with them.
Like dragging a really long extension cord across a room.
That's a perfect analogy. The natural lymphatic drainage of the testicle travels straight back up that extension cord, deep into the retroperitoneal lymph nodes in the back of the abdomen.
Right.
But the scrotum itself has a totally separate superficial drainage system that leads straight to the groin.
Oh.
So if a surgeon cuts through the scrotum to remove the tumor, they alter that plumbing. They risk spilling microscopic cancer cells into a completely different lymphatic highway, scrambling the map and making the cancer far harder to track.
That is brilliant. Altering the surgical route just to respect the lymphatic highways?
Yeah.
But removing that primary tumor creates a new, incredibly anxious waiting game. Because even with a perfectly executed surgery and clean scans, we face the clinical stage dilemma.
Yes, the stage I dilemma. This is the stage where 85% of seminomas and 60% of non-seminomas are initially caught.
Right, the visible cancer was entirely contained to the testicle.
Yeah.
The blood markers are dropping. The scans are perfectly clear.
But we just don't know if microscopic cells have already escaped.
It's like finding a small fire in your kitchen and successfully throwing it out the window. Now you have a choice.
How so?
Well, do you set up a high-def security camera in the living room just to watch closely and see if a stray spark caught the rug on fire? That's active surveillance.
Right.
Or do you preemptively spray the entire living room with a heavy-duty fire extinguisher, knowing it will cause serious water damage to your furniture, just to be absolutely certain? That's adjuvant chemotherapy.
The guidelines stress that patient autonomy dictates this decision, because for low-risk cases, the survival rate is practically 100%. So the preferred option is active surveillance, keeping the security cameras rolling.
Because you don't want to spray the extinguisher if you don't have to.
Exactly. There is no need to introduce highly toxic chemotherapy if the patient likely doesn't even need it.
But the stakes shift dramatically if the pathology report from the surgery reveals higher-risk features.
Right. Oh, totally. For example, if a non-seminoma tumor shows what's called vascular invasion, meaning the pathologist physically saw the tumor actively breaking through the walls of the blood or lymphatic vessels under the microscope, the odds of microscopic spread skyrocket.
So in those high-risk stage I cases, doctors recommend spraying the room.
They do. They deploy one single cycle of a chemotherapy cocktail called BEP, or a single dose of carboplatin. And that one cycle drops the relapse rate from nearly 50% down to under 5%.
Wow. But the strategy fundamentally changes when the security cameras detect that the fire has already spread, right? Like when those deep lymph nodes in the abdomen are visibly glowing on the CT scan.
Yes. That takes us out of the stage I dilemma and drops us right into the systemic chemical warfare of metastatic disease.
Which sounds intense.
It is. The guidelines manage this phase using the International Germ Cell Cancer Collaborative Group, or IGCCCG, classifications.
Okay, the IGCCCG. Say that 5 times fast.
Right, but they sort metastatic patients into 3 prognosis groups: good, intermediate, and poor. And this sorting dictates the intensity of the chemical warfare.
But even for a patient in the good prognosis group, where the cancer has already metastasized to the lymph nodes or lungs, the 5-year survival rate is still a staggering 95%.
Which is incredible for metastatic cancer. But achieving a 95% survival rate requires incredibly potent weapons.
Here's where it gets really interesting. The standard protocol for that is 3 cycles of the BEP chemotherapy cocktail. Let's look at the actual mechanisms of these drugs, because they are essentially poisons calibrated to kill the cancer slightly faster than they kill the patient.
It is exactly that. We are attacking the cancer's cellular replication machinery from multiple angles. Let's unpack the BEP acronym.
Okay, start with the E.
The E is etoposide. It targets an enzyme necessary for unzipping DNA strands. If the DNA can't untangle, the cancer cell can't divide.
Got it. And the P.
The P stands for platinol, which is the brand name for cisplatin. Cisplatin is a heavy metal platinum compound. It physically binds to the DNA inside the cell and cross-links the strands together, basically triggering cellular suicide.
Brutal. And the B is bleomycin, which has a very specific and scary profile of collateral damage.
Yeah, bleomycin physically breaks DNA strands apart. It is highly effective against germ cell tumors, but it is notorious for severe lung toxicity. I mean, it can trigger pulmonary fibrosis, essentially laying down heavy scar tissue inside the lungs.
So if a patient is a heavy smoker or has asthma or like reduced lung capacity, deploying bleomycin could permanently destroy their ability to breathe.
Exactly. And the guidelines are explicit about this. If there are contraindications for bleomycin, the oncology team must swap it out.
What do they swap it with?
They typically replace it with a drug called ifosfamide, shifting the patient to what's called a VIP protocol or an EP protocol. The poison must be tailored to what the patient's specific physiology can actually withstand.
Speaking of what the body can withstand, the collateral damage isn't just pulmonary. The sources detail this massive cardiovascular risk, specifically a clotting crisis.
Oh, the clotting risk is terrifying.
Yeah, patients undergoing this BEP chemotherapy have an astronomically high risk of thromboembolic events, or TEEs.
Right. There was this comprehensive study out of Denmark that compared germ cell tumor patients to men without the disease. The patients actively undergoing BEP chemo had a 24.7 times higher risk for venous thromboembolism within their first year of treatment.
24.7 times higher.
It's massive.
I mean, curing the cancer while introducing a 24 times higher risk of dropping dead from a pulmonary embolism requires some intense mitigation.
Get the mods. The guidelines recommend prophylactic use of low molecular weight heparin, or LMWH.
Which is a blood thinner, right?
Yeah, it's an injectable blood thinner given during the chemo cycles, and studies show it cuts the risk of deep vein thrombosis almost in half.
There is also this fascinating mechanical adjustment to the plumbing to stop the clots. The guidelines explicitly tell doctors to avoid using indwelling vascular access devices like central lines or portacaths whenever possible.
Yes, they want nurses using standard peripheral IVs in the patient's arm instead.
Because a central line is like a long plastic tube sitting semi-permanently inside a major central vein. So when you combine a foreign plastic object with a cancer that naturally thickens the blood, plus chemotherapy drugs like cisplatin that actively damage the endothelial cells lining the blood vessels.
You are building the perfect biological scaffolding for a massive blood clot.
Right, so the oncology team opts for peripheral IVs to minimize that mechanical risk, basically accepting that it means subjecting the patient to more frequent needle sticks in the arm.
It's a trade-off, but a necessary one to save their life from a clot.
Okay, so let's say the patient survives the blood clot risk, they navigate the lung toxicity, and the chemo cycles finally conclude. The next step is evaluating the battlefield.
Right, looking for residual masses.
Exactly. If a patient has a residual mass left over in their abdomen after all this chemo, my instinct would be to throw them immediately into a PET scan. I mean, PET scans highlight hyperactive sugar-hungry cells, which is the defining trait of cancer. Isn't PET the ultimate cancer detector?
This raises an important question, actually. A PET scan seems like the ultimate detector, but the guidelines reveal a highly counterintuitive reality, specifically regarding those slower-growing seminomas we talked about.
Okay, what happens with seminomas?
In seminomas, if you perform a PET scan on a residual mass right after chemotherapy, 75% of the positive scans are false positives.
Wait, 75%. So the body's own healing process is effectively tricking the most advanced scanning technology we have.
Exactly. When the chemotherapy obliterates a large seminoma tumor, it triggers an intense desmoplastic reaction.
Which is what exactly?
It is a massive, localized, inflammatory scarring process. The battlefield is littered with dead cancer cells, and the immune system rushes in to clean up the debris and lay down fibrotic scar tissue.
Ah, and that takes energy.
A lot of energy. All that intense cellular cleanup and reconstruction requires massive amounts of sugar. So the scar tissue devours sugar just as greedily as a tumor does. It lights up the PET scan, making it look like the cancer survived, when in reality, it's just heavy construction work by the body's repair crew.
The blunt force of the sledgehammer leaves a confusing mess, basically,
It really does.
which pushes the guidelines into the final frontier. How science is trying to make this process smarter and sharper so we can finally retire the sledgehammer.
And the most promising evolution there is detailed in the personalized medicine section. The focus is on serum microRNAs, and the star player currently in trials is called MIR371A3P.
These are the liquid biopsies I've heard so much about.
Exactly.
Because if the old tumor markers, the AFP and BHCG, are like a smudged fingerprint at a crime scene that sometimes doesn't even show up, this new microRNA acts like a high-definition 4K security camera.
That's a great way to put it. From a simple blood draw, it can actively differentiate between a seminoma and a non-seminoma.
Yeah.
And the circulating levels correlate incredibly tightly with how well the tumor is actually responding to the chemotherapy.
That is game-changing.
The potential is massive. But the guidelines do temper the excitement a bit by noting it isn't quite ready to entirely replace standard clinical care yet. It has one major blind spot.
Perfect blind spot.
It cannot detect mature teratomas. Teratomas are a specific type of highly differentiated tumor that can be left behind after chemotherapy.
Which becomes a major issue when dealing with late relapses, right?
Exactly. A late relapse occurs when the cancer returns more than 2 years after the patient was supposedly cured. It happens in roughly 2 to 3% of patients. And the returning mass is frequently a slow-growing teratoma or a yolk sac tumor, which that liquid biopsy might completely miss. Treating a late relapse is exceptionally difficult. It requires highly complex radical surgery, an RPLND, where a surgeon literally manually cleans out the retroperitoneal lymph nodes, followed by high-dose salvage chemotherapy.
Just navigating late relapses brings us to the final and really sobering section of the guidelines, survivorship.
Yes.
There is a heavy irony to the success here, because the medical system is exceptionally good at saving these 20-year-old men, giving them that 95% cure rate.
Right.
Those survivors now have to live for 50 or 60 years carrying the chemical ghosts of their treatment.
If we connect this to the bigger picture, the guidelines dedicate significant attention to long-term toxicity. We mentioned earlier that cisplatin cross-links DNA to kill cancer.
Yeah, heavy metal platinum.
Right, but that heavy metal platinum also stays in the body, creating long-term oxidative stress on the endothelial cells lining the blood vessels. It actively accelerates cardiovascular aging. It increases the risk of metabolic syndrome. It also increases the risk of developing secondary, completely different cancers decades later because the radiation and the chemotherapy damaged the DNA of healthy cells.
It just lingers forever.
It does. Furthermore, a huge percentage of these survivors face chronic, debilitating fatigue and permanent hypogonadism, meaning their testosterone production is severely damaged, requiring lifelong hormone replacement therapy.
The bodies of the survivors carry the invisible scars of the chemical war. But it seems the guidelines actively try to protect the survivors from the very medical system that saved them.
They absolutely do.
Like the most prominent example is the push to shift long-term surveillance imaging away from CT scans and toward MRIs.
Yeah, because a standard CT scan relies on ionizing radiation. If the protocol requires scanning a 25-year-old man every single year for 10 years to monitor for a relapse, you are exposing him to a massive cumulative dose of radiation.
And that radiation could, ironically, trigger a secondary malignancy later in life.
Exactly. By transitioning the abdominal surveillance to MRIs, which use magnetic fields instead of ionizing radiation, doctors drastically cut down that lifelong toxic exposure.
Pulling all of this together, we've basically traced the path from an initial mysterious mass and some strange back pain through a heavily codified algorithm of precise inguinal surgeries, timing the half-life of blood markers and navigating a minefield of chemical warfare that yields an astounding survival rate.
It really is a phenomenal synthesis of surgical precision, mathematical tracking, and systemic therapy.
Hopefully for you listening, this deep dive proves how modern oncology isn't just about killing cancer. It's a multidisciplinary tightrope walk. It requires preserving a young man's fertility, protecting his lungs from irreversible fibrosis, actively manipulating 5E placement to avoid catastrophic blood clots, and managing his cardiovascular health for half a century after the war is actually won.
Like we said at the start, diffusing the bomb requires absolute mastery of the entire system.
Which leaves us with a final thought for you to ponder. Testicular cancer treatment is objectively one of the greatest success stories of modern medicine, essentially turning a deadly disease into a highly curable one. But when we deploy such highly toxic weapons to save a 20-year-old's life, are we simply trading an acute fatal disease today for a chronic cardiovascular disease tomorrow? And as those high-def liquid biopsies advance, how will the playbooks of tomorrow change this brutal but beautiful math? Thank you for joining this deep dive into the ESMO Urican guidelines. Keep questioning, keep exploring, and we'll catch you on the next one.